Hello, I'm Antoni Chan. I'm consultant rheumatologist from the United Kingdom, reporting here at ACR 21 for Room Now. And today I have a great pleasure of having Professor Oliver FitzGerald, a key opinion leader in the field of psoriatic arthritis, joining me here for a discussion about some of the highlights from ACR 21. So, Professor FitzGerald, welcome to this interview.
Thank you very much,
And
Tony.
one of the highlights that we've seen at the ACR 21 conference are the new therapies in psoriatic arthritis. And I was very interested to read your work on the TYK2 inhibitor, deucravacitinib, in PSA. That is poster 490. I wonder whether you could give us some key highlights from the study.
Sure. So the poster is a product of work done on the phase 2 trial of deucravacitinib in psoriatic arthritis. And the results of that trial were reported at the same session by Philip Meese. So essentially, deucravacitinib is a highly selective TYK2 inhibitor which in the phase 2 trial proved to be effective for a number of the domains that are important in patients with psoriatic arthritis, with deucravacitinib resulting in improvements in both joint and skin domains, in addition to domains like enthesitis, HAC-DI, and some of the patient-reported outcomes were also significantly improved in the treated patients as compared to the placebo-treated patients. So a nice positive study. And I guess what this particular poster is focusing on are the effects of deucravacitinib on disease markers and tyrosine kinase 2 mediated pathways. So the initial markers that they were interested in looking at included those mediating signaling of IL-23 and type 1 interferon, which are in particular targeted by the TYK2 inhibitor. So IL-23 and IL-17 pathway biomarkers, such as IL-17A, BD2, and IL-19 were measured, as well as interferon-inducible chemokines like CXCL9 and CXCL10. Other inflammation pathways were explored, so IL-6, CRP, and TNF-alpha, and then markers of joint damage and tissue function, such as MMP3 and C4M. So the study showed that there were significant reductions in IL-17A, IL-19, and BD2 in patients treated with deucravacitinib as compared to placebo. So that was good. That's what we expected. There were also reductions seen in type 1 interferon-inducible proteins as compared to placebo. And inflammatory markers such as CRP, IL-6, and TNF-alpha were also significantly reduced in the treated patients. So all of that was consistent with what we expected with the mechanism of action of a TYK2 inhibitor. Furthermore, one of the things we wanted to look at was whether or not the deucravacitinib affected features like NK cell counts or hemoglobin or lipid profiles such as total cholesterol or liver function, all of which have been noted to be affected by JAK1, 2, or 3 inhibitors. And the results of this phase 2 study would suggest that these particular parameters were not affected by deucravacitinib. And if anything, there was a small increase in hemoglobin seen in the patients treated with deucravacitinib. So all that suggests is that this is a highly selective TYK2 inhibitor that doesn't appear to be associated with some of the side effects that have been seen with other JAK inhibitors, which is good. And other safety issues like herpes zoster and serious infections also were not seen in the phase 2 study. Now, this is a phase 2 study. Phase 3 is yet to come. So we'll just have to see how that goes when the phase 3 study is done. I look forward to seeing those data in due course. I don't know whether that explains the poster, Tony?
Yes. Yes, thank you very much. That is very nice to see the biological or cytokine effect, and then correlating it back to, as you say, some of the clinical outcomes. I think the selectivity, we're learning about this new kind of agent, a tyrosine kinase inhibitor. We are a bit more experienced in using JAK inhibitors, and I think the selectivity. Do you think we will see that? And what is it? What do you predict in terms of in the phase 3? Do you think that that will come through? Obviously difficult to know without actually doing the study, but in terms of say for example infection risk, that we are slightly more some concerns with the JAK inhibitors. Do you think we will see maybe less of that with this?
I would anticipate that we will see less of it, and the I think that relates to the specificity of the inhibitor for TYK2, and it doesn't seem to spill over to blocking other JAK1, 2, or 3 proteins, I guess, are not being affected in the same way as with other JAK inhibitors. So, yeah, I'd be hopeful it'll work out well.
Which is will be good news for our patients, and I suppose the patient selection will also factor into that, whether they have other comorbidities or anything else
Ex-
associated with infection
ex-
risks. Yeah.
Exactly, and that's obviously a big concern in some of the patients that we treat, is that they do have not infrequently comorbidities that may determine which medication you might or might not use.
Yeah, so a new therapy. We look forward to phase 3 studies, and if you could think about these patients, where would this treatment be sort of best placed in the? We have increasing number of agents now to use
Mm.
in psoriatic arthritis.
Yeah.
If you had to kind of decide on where best to treat them, where would you think this would fit, or could it fit anywhere along the pathway?
Well, at this point, I don't think we can be specific enough with the information that we have as to where this medication would best sit. The fact that it seems to be in particular targeting the IL-23, IL-17 pathway would suggest that it may be effective in particular for those patients who have skin disease, axial disease. These are diseases that the IL-17 inhibitor appears to be quite effective, but that's not to say that it might also be particularly effective in patients who have bad joint disease. So I think there's still a lot we need to learn about the medication.
Yeah, so it's very nice to also see that there are other abstracts on the same agent, deucravacitinib, looking at some of the other sort of patient-related factors, and also sort of more holistic assessment of the patient. So we do look forward to seeing more data coming up for this treatment. Were there any other highlights for you at ACR 21 in terms of psoriatic arthritis?
Yeah, I went to a couple of sessions that I found certainly of interest. One of the sessions of which I think we'll be hearing a lot more about is the use of PET-CT scanning. I don't know whether you might have seen that one.
Yes.
In patients with psoriatic arthritis. I thought some fantastic images were shown of the specificity of this PET-CT for areas of inflammation, whether it be in the joint or in the spine, or in some of the images in the vessels that appeared to be taking up the marker as well. It was the FDG marker. So, yeah, and I think that's something that could prove as was suggested by the presenter, Siba Ratchuri, that it could be useful in picking out patients who are who have psoriasis, who may be in the process of developing psoriatic arthritis. So that could be one particular benefit of using PET CT scanning, or it could be in following patients' response to treatment. And I think he had a nice slide where the activity showing on PET CT was downregulated by, I think it was an anti-TNF therapy. So very interesting images, and I thought that was good.
Yeah, it was a very, very interesting talk. Yeah. And I think it showed the burden of disease in psoriatic arthritis, that a lot of subclinical disease was probably more than what we think. And I think that my takeaway from that was that the PET CT could be used in terms of quantification of burden of disease. And I think they made a comparison with ultrasound and the differences between the two. So clearly more work to come in this area.
Yeah, I mean,
Any
ultrasound is
other
great,
highlight?
but it needs to be
Yeah,
focused, doesn't it? You need to focus the
yeah.
ultrasound on the joint or wherever you're looking at, whereas this was looking at everything all at once, so it was, looked good. Yeah. Sorry, you were
More
asking,
holistic
Tony.
assessment. Yeah, was there anything else before we kind of come to the end of our interview? Were there any other highlights that you'd like to share with us from ACR 21?
Well, I'm going to mention a further abstract of our own,
Okay.
where we looked at biomarkers of radiographic progression. So this was a study we conducted with Lilly, and this was conducted by GRAPPA and by ourselves at UCD and at Aturos, which is a small spin-out company here in UCD. But what we did was we looked at, we compared, I guess, the proteins being expressed at baseline in a small number of people whose disease progressed radiographically as compared with those that did not, and showed that there was a panel of proteins that appeared to be present at baseline that predicted progression to radiographic damage. And I think that potentially could be important as well. So something that we will need to follow up on with a larger cohort, but the ability to predict which patients are going to progress radiographically has been a goal of GRAPPA for quite some time. So this is perhaps making some progress in that direction.
Yeah, so that hopefully will get us closer to more personalized medicine in terms of
Precisely.
choosing our therapies and then kind of following them. And hopefully we'll get some candidate proteins from your sort of study to kind of target on in the future.
Precisely.
So thank you very much, Oliver. It's a great pleasure to talk to you as always on key
Thanks, Tony.
updates on psoriatic arthritis. So I'm Antoni Chan, and it's a great pleasure to have Professor FitzGerald with us this afternoon. Thank you very much.
Thank you.